Please go ahead.
Hello. So thank you very much, the organizing team, for giving me this opportunity to share my experience. My case is about a badly placed RSA, how bad it is. And she's 75 years female, 10 months post-operated reverse shoulder arthroplasty. Basic complaint is not exactly the pain. She's been in physiotherapy for 10 months and practically no range of motion. She's not able to elevate the arm or do any forward or any rotations. 75 years, but still very active, mother of a surgeon herself. And when I did an X-ray, this was exactly how it was placed. It is not cut through or not mobilized, not misplaced or sort of any glenoid side. It was exactly how it was placed. And as we all know, the basic principle of the reverse shoulder arthroplasty is medialization and distalization of the center of rotation and increasing the lever arm of the deltoid so that it can work from the initial ROM for abduction and forward flexion, and definitely it doesn't look like it would work in this particular scenario. So she is not able to do any movements. And recently Pascal Paulo and Jill Swals and the team published a very good article on overall evaluation of RSA and in Journal of Shoulder and Elbow Surgery. And one of the sentence which is very much relevant to this is the optimal position of the reverse base plate is inferior on the glenoid and without superior tilt in attempt to optimize the impingement free range of motion while avoiding scapular notching and glenoid loosening. So just basics, this is how the total shoulder works and this is how the TSA angle has been defined as. But when it comes to reverse shoulder, it has to be the inferior quadrant of the glenoid, and it is very well aware, very well known to all of us. So I decided to revise. My plan was to revise the glenoid side of it, and I wanted to retain the humeral side. It was a difficult revision to start with because over the original incision was also not from which I go in. And there was lots of fibrosis. I did neurovascular releases and everything. But more difficult was the base plate removal because it was a tough bone superiorly, and it was all after 10 months of rehab. And it was the bony growth and everything, it was difficult. And there was some cold welding also in the screws in the glenoid base plate. But fortunately, or unfortunately, I was able to remove the base plate and did revision on the glenoid side. And when I saw the first X-ray post-operatively, though the glenoid side was looking good, but I was definitely not very happy and frustrated seeing the X-ray for two reasons. One is very evident, as you all see, the fracture of the acromion or spine of the scapula, and more importantly, after doing so many RSAs, I was not happy with the inclination of my own glenoid base plate. And there are multiple studies, multiple reports which says if it is not well inclined or if it is more inclined, then definitely there are more loosenings, more failure rates, and definitely more notching after certain years of the RSA. So when I retrogressively thought why I was not able to retain this inclination post-operatively, one definitely was a high adrenaline level after removing the base plate and everything. I was not able to actually see the glenosphere, see the glenoid itself very well with all those fibrosis because it was so superiorly placed that inferior everything was very, very much fibrosed. But that if we keep that excuse apart, with this type of removal of the implant and everything, it eventually converted into FAVA type E1, that is centrally erosive type of glenoid bone loss. And what I did was I just implanted the base plate without any planning or anything like in A and B, and so I ended up with superiorly inclined base plate. What usually we do is eccentric reaming, as it been seen in C and D, to have a proper inclination. But because she was osteoporotic, her original, the DEXA scan score was less than minus 2.5. She was very osteoporotic. So I was quite scared of doing eccentric reaming and doing more bone loss inferiorly. And that was one of the reason I ended up with superiorly inclined base plate. Probably a better option would have been a superiorly augmented either metallic or bio RSA base plate, and that probably would have ended a better inclination. But as they say, or nowadays we do have a very very nice softwares, CT scan base, in which we can plan how much inclination or what type of augmentation we require intraoperatively. Probably these are the cases in which it adds the value, and I have decided to use in such type of revision cases, so that I do not end up with this type of issues. There are multiple articles, but if we just present the very authentic ones, the scapulonochic in reverse shoulder arthroplasty, the influence of angle, again it says that if there is a superiorly inclined base plate, then definitely there are more notching, and this particularly say that it leads to tensile base plate forces and may be contributing to early loosening, and these are all well evident studies. And if we see my case also after a year of X-ray, and this is a 1 year follow-up X-ray, and what I can see is there is definitely lots of loosening and notching, though a patient has a good functional outcome, but I really doubt how she will survive this after 5 years after 5 years. And the other complication, if we talk about, is definitely the fracture of the acromion process. Now that also, when I thought retrogradely whether I would have predicted or prevented the acromion or spine of scapula fracture in this particular case, then it was a 10 months of shortened deltoid due to superiorly positioned glenoid. The deltoid was very much superiorly placed, so the base plate. So that deltoid lever arm was shortened, and immediately when I did RSA, revised the RSA, it was very well advanced and lengthened. And as we discussed, she was very severely osteoporotic with T-score less than minus 2.5. There are now multiple studies like Otto and Crosby team. They say that superior and posterior glenoid base plate screws, they create stress riser, and that probably leads to the spine of scapula or acromion fractures. So we should be avoiding this screws, and now there are evidence study that even 2 screws are more than enough for the base plate. And these particular screws can be avoided if you have this type of risk factors in this elderly age group with revision cases. I don't know about, but probably this would have added some value to it. So this was the post-operative CT scan after the revision, and what I see, it was a completely, the conservative management of the acromion fracture was not possible because, and what we did is we opened up, we first applied 1 plate, but the bone was very weak, and we were not very happy with the screw hold. So we did 2 plates, and end of the day, after 1 year of follow-up, the fracture itself is united and there is no pain on the fracture side, but definitely the X-ray does not look very promising for the future. And range of motion, surprisingly, patient is happy without pain right now, but definitely I am not sure how much more painful she would be. So this is something which I learned from my case and wanted to share on this particular panel. Thank you.